Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hi, and welcome to the GRACE Supportive Care webinar series. My name is Arjun Gupta. Today, we have Dr. Dawn Hershman joining us from the Columbia University in New York, where she's a professor of oncology. Our topic of discussion will be Aromatase Inhibitor Induced Arthralgias. Dr. Dawn Hershman is an expert in breast cancer and also symptom management, and we could think of no one else better to speak to us about this. So for our viewers out there, AIs or aromatase inhibitors are a class of drugs often used to treat breast cancer. Approximately 70 to 80% of breast cancers are hormone receptor or estrogen receptor positive. Whether someone has a breast cancer that's been surgically removed and they have no detectable tumor in the body, or if they have stage 4 or metastatic disease in the body, these patients are often put on hormone receptor therapy or endocrine therapy, which may last for years. These musculoskeletal symptoms or AI-induced arthralgias are a common cause why patients suffer and also tend to discontinue therapy. And that's what we're here to talk about today. So welcome, Dr. Hershman.
Thank you. Thank you for having me.
Perfect. So just to start, could you tell our audience about AI arthralgias, who gets them, maybe some statistics, and what are patients usually presenting to the clinic with?
Sure. So it's useful to sort of think about the background of endocrine therapy and how aromatase inhibitors sort of became so popular. So, originally we used to treat all women with tamoxifen until a pivotal trial looking at the comparison of aromatase inhibitors to tamoxifen came out. And at that time, the aromatase inhibitors looked like they were better in terms of efficacy, but more importantly, it looked like they were better in terms of toxicity because the aromatase inhibitors did not result in uterine cancer or blood clots, serious adverse events that were uncommon but attributable to tamoxifen. However, when we first started to use these agents, patients would come in and say, I don't know, this medicine makes me feel like an old lady. I can't get out of my chair. I feel like I can't open a jar. I don't really understand. And when we went back and looked at the clinical trials, it didn't really report anything like that. And part of the reason why was because it was an era where we really didn't ask patients about their symptoms. We were really only interested in whether or not a patient had a very serious adverse event, but we really didn't measure chronic lower grade adverse events that have a big impact on patients' quality of life. So the first thing we did in our group was we just started asking patients. We did a consecutive survey of 200 patients and asked about their symptoms of joint pain and arthralgias and how much it interfered with their functional status. And we're shocked to find out that 50% of patients reported symptoms of arthralgias. About half of those were new in onset from when they started their medication. About half had some joint pain beforehand, but it got much worse when they started to take the aromatase inhibitors. And about, while 50% of patients had symptoms, about a quarter of those had severe symptoms so severe that it interfered with the quality of their life or their functional ability. And we know as a practicing clinician, patients come in almost in tears, sort of with this dilemma, knowing that their medication is supposed to prevent recurrence and it's so effective, but it makes them miserable and they don't know how they're going to sort of continue it. So that's what got us interested in these medicines and thinking of novel ways to try to control the side effects of these medications.
And so now these aromatase inhibitors have been on the market for 25 years or so. We have some experience in sort of how patients present, how to go about assessing them, why we think this is happening. Could you speak a little bit about what we suspect the pathophysiology to be? Are these side effects usually experienced pretty quickly after patients start therapy? And what symptoms do patients often present with to you in clinic?
Yeah, so it's actually interesting because it's the reduction in estrogen that seems to result in joint discomfort. And we don't 100% know why that's the case. There are estrogen receptors in cartilage. There are some studies that suggest that there's some inflammation when you look at MRIs, but the exact mechanism is not known. It's actually interesting because when they used to want to study arthritis, one of the mouse models they used was removing ovaries from the mice. That was how they studied arthritis in mice. And so, that there's clearly a direct effect of estrogen on the joint. So whether it's the speed with which the estrogen goes down or the degree or what factors may make some people more susceptible, we really don't know. There are some risk factors. Body mass index is a risk factor for development of arthralgia. It's actually patients with no symptoms when they start seem to have worse complaints than patients that have a chronic arthritis. They don't notice it as much. And it does seem to be worse in people who are just recently perimenopausal or menopausal compared to those that are many years out. But it's interesting, some patients get symptoms immediately and then they sort of gradually fade away as they their body adjusts to being on the medication. And other patients seem to have a delay in terms of the development of symptoms, and then they sort of persist. So we really don't know up front how to characterize who's going to get what. But the majority of patients complain of stiffness, meaning that they're okay if they don't move, but if they need to move from one position to another, that's when they really feel it. And it can interfere with things like people that have to do manual tasks. Some people get a carpal tunnel-like syndrome. Usually it's things like going up and down the stairs or getting out of a car after they've been sitting for a long time. But people that have to do more with their hands may notice it more.
Perfect. And when patients are coming to you with these complaints or calling the helpline or you're seeing them in clinic, is this mostly a clinical diagnosis that you're making based on their symptoms and a physical examination, or does this need extensive lab or imaging investigations?
Yeah, it really doesn't need anything more than talking to somebody. There's not any specific physical exam finding associated with it. There's no reason to do MRIs or investigations looking for it. Obviously, you want to think about reversible causes or other causes and not just assume it's this, but it's pretty classic after you start somebody on it. You obviously don't want to miss rheumatoid arthritis or something else, that some other inflammatory process that's going on. But I think, usually you prepare patients that this is a symptom that they may get. I usually say, what the symptoms typically are. But I tell patients if they have it and it's severe, not to just stop taking their medication, but to call us first to see if we can come up with a strategy.
So now you're in clinic seeing a patient with, say, stage 2 breast cancer who's receiving 5 to 10 years of adjuvant therapy with letrozole or another aromatase inhibitor. And they started it approximately 2 months ago, now coming to you with severe hand stiffness, they like knitting and they're unable to do it. Are there behavioral modifications, is it medications? How do you go about it?
Right. Well, there are a variety of different strategies, both pharmacologic and non-pharmacologic, that have been used to try to ameliorate the symptoms. Sometimes we want to make sure that it's really from that. We'll stop it for a week or two just to see if it gets better. And then actually sometimes I slowly restart just to sort of get them back on a medication or switch to another class just to make sure it's not a class effect. I always tell patients that it's important to exercise, stretching, other kinds of physical activity are important. We were part of a clinical trial that looked at exercise and found that patients that exercised had reduced joint symptoms from their aromatase inhibitor arthralgias. Another option is duloxetine, which has also been studied in clinical trials. It is a medication that's sometimes used to help with other painful conditions, and it can help with depression. So depending on a patient's global symptoms, we find that a lot of patients don't want to start another pharmacologic medication to treat the side effects of a medicine that they have to take. So that's usually not a very popular medication, but a medication that does have clinical trials to support its use. Other things that have been tried, we conducted a large trial of acupuncture. Acupuncture is known to reduce pain in a lot of different painful conditions. It's quite effective at reducing the symptoms. Often patients can start with a more standard regimen of acupuncture twice a week and then taper off. And we found that those reductions in symptoms can persist for a period of time. The other thing we looked at was omega-3 fatty acids. And while when we studied it compared to placebo, both groups had a significant reduction. But when we looked at the subset of patients that had higher body mass index, where you may anticipate maybe a higher inflammatory component, there was a reduction with the use of omega-3 fatty acids compared to placebo. So there's still a lot of ongoing trials to try to figure out the best strategy for the right, the person to sort of personalize these approaches, but we definitely need better ways to control or even prevent the side effect.
Is there any role, Dr. Hershman, of using pain medications, whether that be over-the-counter Tylenol, ibuprofen, Aleve, or something stronger, such as opioids, to manage the pain and stiffness in these in AI arthralgias?
Yeah, I mean, the over-the-counter anti-inflammatory medications definitely can reduce some of the symptoms, but there are also problems about being on those medications long term. They can increase your risk of bleeding. They can have an effect on your cardiovascular system. So it's okay intermittently, but you have to be careful. And Tylenol may be a little bit safer in lower doses, but you don't want to be on chronic higher doses of Tylenol. I would not suggest starting an opioid for this kind of stiffness. It's far better to try to focus on non-pharmacologic interventions. We know the addictive potential of opioids, and it's probably not a great thing to consider when thinking of this type of discomfort.
All right, so suppose you try all of this and you sort of go down the algorithm and someone truly has very, very refractory symptoms and maybe even ongoing symptoms despite doing all of this, and maybe even pausing therapy with an aromatase inhibitor. Obviously, you have a risk-benefit talk with the patient about the advantages and disadvantages of stopping endocrine therapy completely. What can you do if you really can't try to figure out how to make their pain and stiffness better? Is there something else that you can give?
First of all, we sort of lose track of the fact that we have other hormonal medications we can give. The difference between tamoxifen and aromatase inhibitors is very small, and there's no survival benefit associated with the aromatase inhibitors. It's very important to tell patients that they can get equal efficacy and sometimes less joint symptoms from taking tamoxifen, and that they while there are some side effects, they're rare and usually not symptomatic and can be monitored. So we usually want to stress that they have other hormone therapy options that they can try. If they are not a candidate for tamoxifen, then sometimes we even are investigating whether or not lowering the dose of the aromatase inhibitor can be effective. There are ongoing clinical trials that are looking at altered dosing of aromatase inhibitors and altered schedules. And when those results come out, I think it will help us know whether or not maybe we can get away with giving less of the medication and still having benefit. That's our hope anyway.
Wow, because there was some emerging data that lower dose tamoxifen might be as safe and effective as higher dose tamoxifen. So one of the things you're saying is maybe there's something on the horizon for that happening with the aromatase inhibitors as well.
Yeah.
Anything else, Dr. Hershman, that you'd like to tell our audience about things to look forward to or some cool research that you're up to right now?
I mean, I think it's most important to, if you're having these symptoms, to engage in a conversation with the oncologist and partner with them to try to figure out a strategy. Sometimes the benefits are so small because the patient has such a low risk cancer, it's not worth it. But other times the patient can get a substantial benefit, and we need to think of creatively of solutions that may be best for that particular person sitting in front of us.
Perfect. Well, thank you very much for joining us. And we hope that when we redo this talk in a couple of years, we'll have plenty new treatments to talk about.
Yes, hopefully that will be the case.
Thank you, Dr. Hershman.
Sure.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, and Takeda. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.